The Masterclass on Future of Healthcare Digital and Beyond by J. Satyanarayana has been interesting and informative. Now we have a question and answer round. Our first question is: queue at reception could be managed by QR, but how to manage the queue and crowd in front of the doctors at OPS?
Yeah, absolutely. So it's an important observation. As I mentioned before, let me disclaim that queues will be abolished forever. There will be some waiting, definitely at the, as you rightly said, at the OPD. While it is definitely possible to minimize the queue in the OP registration side, etc., when they again converge towards a particular specialist or doctor, again there is some waiting there. So several things can be done there. One is the doctor himself, herself can be, or specialist can use the tools of, clinical decision support system. And the triaging can be done also. There are applications that the people are sitting, waiting for the doctor. Lot of pre-information about their problem can be canvassed by people who are less experienced, but they can do these routine things and triage them and keep the basic data ready for when they go to see the doctor. So the waiting time is also optimized by collecting necessary information by trained people in the consulting, outside the consulting room. That is one way. Second is when they go inside and meet the doctor can be more efficient by using these clinical decision support systems. Two things. And also in future, the doctor need not take a pen and paper, and then he can just describe the case orally, and it's automatically understood and converted into an electronic medical record. So these are all realities which in our project, which I will show in the part B, we examined all those possibilities. Yeah.
Major issue is non-interoperability of different systems and no incentives for hospital staff, especially doctors, to change the ways or change status quo.
Yeah, another important question, especially in the healthcare sector, this is a very, we have seen, huge change management. Initially, when we started 30 years ago, me and Prakash were probably entering service at that time, where the banks were computerized and a huge resistance to change. And then it was overcome through conventional methods, etc., over a period of time. But currently, it is not so, the resistance to digitalization is not so big. People have seen the, the good side of it and the beneficial part. So, but still globally, because I have seen several countries at the ground level, we went down to PHC, the primary village level hospitals in not only India but other countries. It is the same. That the doctor would like to write it on a piece of paper than would like to use the system in front of him or her. So this is a capacity building and change management initiative has to necessarily accompany this program. Otherwise, the realization of the benefit will be suboptimal again. Or they may just keep the computer closed also, So what are the factors? Number one, the doctors feel that, they would rather spend the time on the patient rather than on the PC. So that can be done through technological means again by training them. Just talk your normal spoken English, and there are a lot of tools available to convert that into a medical record straight away. You have to only verify at the end of the patient's case and then click a button to approve it. So we are close to that, or we are on the way to achieving those things. There are technological solutions to address the queue within the doctor's consulting room as well.
What are the initiatives taken to integrate health records across private and government hospitals?
Yeah, it's a very important question. Interoperability is at the heart of the digital health blueprint. So, I would even exaggerate this problem further, that I perfectly agree that between public and private interoperability is a. But the more immediate question is, within public and public also there is no interoperability today, right? Between one hospital in the public sector and one hospital in the public, another hospital in the public sector again. Between primary health center, secondary care hospital at taluka tehsil level and the district hospital also there is no interoperability. Again, you have to recreate the records at each place. They are different, using different systems or no systems at all. So the problem is definitely there, but that is the reason and provocation for us to prepare the blueprint and the building blocks which I have shown earlier. So there are two pieces there that help. One is adoption of standards that are defined by Ayushman Bharat Digital Mission. The interfaces is called UHI, Universal Health. Today you have all the Google Pays and Phone Pays and RuPays, etc. are so effortlessly being used in an interoperable way across the whole country, across all kind of merchants. This is all because of what is simple thing called UPI, Unified Payment Interface. You replace payment with health, what you call Unified Health Interface. We have already designed the protocols for that, and I have shown a bit of that in the previous slide. So UHI is going to be the, instead of teaching everyone Hindi or one common language across the whole country, you make these languages interoperable, so automatically. That's what we are trying to do. So the protocol is one way. Second is health information exchange, which enables any kind of data to be read and by anybody, any other system. So these two pieces, and a certification mechanism or enabling mechanism called sandbox, which ensures that is really so. So these are the ways we address the interoperability issue. It's not public-private, it is system A to system B, irrespective of whether A is in public or private sector and vice versa. So interoperability is the key element here we are addressing through ABDM in several different ways.
What are the fundamental criteria to determine the services of healthcare? In the context, 70% of healthcare services are under private or NGO hands and remaining in the hands of the government.
So in fact, if you mean quality of service, yes, there are laid down standards. NABH has laid down standards for quality of service. So same thing needs to be applied here as well. That's one of the pillars that I mentioned, is the standards one, that includes not only technology standards but also the domain standards, including the standards to be followed by the hospital or health facility and by the treating physician by following the protocol. So they will be, once you have these in digital form, it's possible to measure even the quality and monitor the quality.
The bottleneck in use of AI in healthcare is data privacy. How do we overcome it? Is adopting data anonymization techniques sufficient to ensure data privacy?
So this is one of the challenges, is availability of data for building or training the AI models. The startups very usually face this kind of a problem, getting to the data, because there are concerns and genuine concerns of privacy and so on. Sharing, no institution would like to share the data. So the question is, that's why the DPDP bill really, and then the kind of penal provisions it has introduced also is really. While we work with the health data management policy so far, it doesn't have teeth, it doesn't have any punitive powers built into that policy, because it's just an executive order. But DPDP Act, I think pretty soon it will come into picture. It has the window for sharing of data for research, and so once you have, if you look at it, about the reasons why people would not like to share the data is because there is no framework to begin with, and there is no threat against any breach. There is no consequence of a breach is not so very serious. But once you have the law in place and the regulations, I hope, will come soon, things will improve and institutions will be willing to share the data, anonymized data, for research and for innovation, for developing AI solutions. And then the consequences of any breach will be very severe. That's why it will again protect the privacy. The purpose of Data Protection Act itself is that, TPTP Act itself is that, it will make it prohibitively avoidable to attempt any breach. So that's a very great difference it will make. So there will be give Philip to research, innovation as well at the same time. There is a balance required in this regard between data protection and innovation, which the preamble of the Act also recognizes that.
Digital transformation is possible mostly in Tier 1 or 2 cities. But how do we implement them in the interiors where there is a lack of basic infrastructure?
So we should actually two things. One is, as you rightly mentioned, telemedicine can bridge the gap to a large extent. The second, from a technology perspective, whatever is available on mobile, we should make it mobile friendly and mobile first policy. One of the principles that I mentioned before, but not elaborate, is the NDHM. One of the principles is mobile first. You should be able to deliver that service on a mobile. Just as today, all payments, everything is happening on mobile only today, fortunately. So with that, we'll have at least as much penetration as PhonePe has done today. We can hope to reach that level pretty soon, because it's mobile friendly, and you can I created my Aadhaar number in 30 seconds using mobile, and likewise, 49 crore people have done it so easily. It takes no more than 30 seconds. So I think it's not a major concern today versus 20 years ago when we were doing different projects.
Hope you enjoyed this masterclass and thank you for watching. Don't forget to tune into our next one.